So I just want to quickly run through a couple of points before we start. I know that you're eager to hear from our panelists, but I want to make sure that I just kind of introduce myself and what I've learned from working on this program for the past 3 years with my other co-planners. I have no disclosures. I'd just like to first thank Dr. Alexander Norbash, who is the professor and chair of radiology at UC San Diego and the faculty co-director of the RLI Leadership Summit overall. He is actually the reason why this program exists. Myself and 3 other residents went to him 4 years ago actually, and we approached him and said that we thought that more residents and fellows could use additional training and leadership, and so this is how this was created. The program this year focuses on ecosystems and what that really means, and I just want to quickly run through kind of an idea of what your ecosystem is. So you have this big idea of this is me, and your ecosystem is a core of who you are, but it's made up of multiple components. So in radiology, obviously, you have, when you're starting out in practice, you may have trainees that you work with. You're going to have your peers. You're going to have people that you report to, like your chair. You're going to have technologists and nurses that you have to work with. You're also going to have ordering providers that are asking you to do certain scans or certain studies. And then you're going to have, in working with those providers, tumor boards, where you're going to be the specialist in that area, talking to them about imaging. You also have your administrative team, committees that you may be working on with the hospital, the billing department, which is huge once you become an attending and you don't realize that as a trainee. Compliance managers, the people that send you emails that say you forgot to put XYZ in your report. And then on top of that, you have your patients, the people that stand behind those scans that you're reading, your family, the pressures of potential family members or friends that pull on your demands. And then of course, your personal health. And so this is kind of what people think about when they think of their core, but there's so many other components to your ecosystem and so many different factors that affect you and that you affect. So I just want you to keep that in mind as you go through this today, and just try and think about the varying ways that you can affect your own ecosystem and be effective on others. And just some things to think about in particular as you listen to the panel and as you listen to the other presentations, ways that you can expand your own ecosystem, learn how to embrace your passions, know how to be flexible, being able to say yes to things when you really are interested, but also how to say no. Understanding the situation that you're in as an early attending and beyond, learning how to seek sponsorship. You can't just get a sponsor, but you can certainly look for someone who may be supportive for you. Knowing how to ask for help, and then finally embracing new roles. So with that, I'm going to move on to our panel, and I'm going to move on to let Dr. Danya Day, introduce our panel.
Thank you, Carrie. And just to briefly introduce myself, my name is Danya Day. I'm an interventional radiologist at MGH, and I'm one of the co-planners of this event. So our first session for this evening will be on how to be successful in your first year and make yourself indispensable in your practice. For this session, we have a great lineup of speakers: Dr. Lucy Spoluto, Dr. Pari Pandaripande, Dr. Joanna Fair, and Dr. Jessica Robbins. The session will be followed by a Q&A with our speakers, and I would encourage everyone to submit their questions using the Q&A button at the bottom of your Zoom screen. Before I turn it over to our speakers, I'll just start with a few introductions. Dr. Lucy Spoluto is a graduate of the University of Virginia and earned her medical degree from the University of Virginia School of Medicine. She completed a residency in diagnostic radiology at Brown University and a fellowship in women's imaging at Vanderbilt University Medical Center. She joined the Vanderbilt faculty in 2014 as an assistant professor and was promoted to associate professor in 2019. Her clinical work focuses on breast imaging, including mammography, ultrasound, MRI, and image-guided procedures. In 2019, Dr. Spoluto completed the VA Quality Scholars Health Services Research Fellowship and the Vanderbilt Masters of Public Health program. She leads an active research program focusing on addressing health disparities, designing health equity-focused learning material for healthcare professionals, and mentoring residents and medical students interested in health equity. Currently, she is the Vice Chair of Health Equity Director of Women in Radiology, an initiative she co-founded in 2015, and Associate Director for the Office of Diversity and Inclusion for the Department of Radiology. She serves on the American College of Radiology's Commission on Patient and Family-Centered Care and Commission for Women and Diversity, and as the President of the American Association for Women in Radiology, AAWR. Dr. Joanna Fair is an Associate Professor of Radiology and Nuclear Medicine at the University of New Mexico School of Medicine. She earned her PhD in Chemical Physics from the University of Colorado and an MD from Washington University in St. Louis. She completed residency training in radiology at the University of New Mexico and in nuclear medicine at the Washington University in St. Louis. She is board certified by the ABR and ABNM. Nationally, Dr. Fair is the recent past chair of the American Board of Nuclear Medicine, as well as former president of the Southwestern chapter of the Society of Nuclear Medicine and Molecular Imaging. She is currently the vice chair of the Women in Nuclear Medicine Committee for the Society of Nuclear Medicine and Molecular Imaging. Dr. Fair currently serves as Senior Associate Dean of Graduate Medical Education for the University of New Mexico School of Medicine, as well as vice chair for academic affairs in the Department of Radiology. Dr. Fair additionally works within the School of Medicine Learning Environment Office. She has spoken regionally and nationally about nuclear medicine, imaging and therapy, feedback, and other topics. Dr. Fair is married with 2 school-aged children and is engaged with community service, including as a Girl Scout troop leader and board member of the National Museum of Nuclear Science and History. Dr. Pari Pandaripande. Dr. Pandaripande is an abdominal radiologist and associate professor of radiology at Massachusetts General Hospital, Harvard Medical School, and is director of the MGH Institute for Technology Assessment, a multidisciplinary health outcomes research institute. In 2019 and 2020, she was promoted to associate chair for integrated imaging and imaging sciences, and she currently leads an enterprise-wide initiative that seeks to clinically integrate imaging practices across the Mass General Brigham network. Pari's career goal is to ensure that every patient's encounter with imaging adds value to their care, and she is deeply invested in advancing the clinical research and educational missions of academic radiology to make this happen. Dr. Jessica Robbins. Dr. Robbins is professor of abdominal imaging and the vice chair of faculty development and enrichment in the Department of Radiology at the University of Wisconsin School of Medicine and Public Health. Her professional interests include advocacy for diversity and inclusion efforts in radiology, gender equity, and leadership development, and her research interests focus on benign and oncologic gynecologic imaging. With this, I'll turn it over to our panel for their talks.
Hi, I'm Jessica Robbins. I'm an abdominal radiologist and vice chair of faculty development at the University of Wisconsin. I'm excited to be here with you today. I have no disclosures. So today I'm going to talk to you about passion in your new career, in your early career, and how you can harness your passion to find success. Before we started in medicine, we may have come from many different backgrounds. Some of us came straight through college. Some of us had other careers before we started medical school. But once we start medical school, our careers and our trajectories begin to converge, and we have very similar pathways. After medical school, we often will go into a residency and fellowship. Many of us will go directly into the residency and fellowship of our choice. And some of us, like me, may have had a little bit of a circuitous course on our course to our residency training. After residency, we often will find our first job. We may become faculty. We may be on a partnership track. But regardless, our choices and our career paths begin to diverge. So the goal early in our careers is to really start to select what path we want to follow and how we see our future career trajectory proceeding. And this is where I encourage you to really look inside of yourself and dream big. Identify what your passion is, what gets you out of bed each day and keeps you going, what motivates you to do a great job and to succeed in your career. What is your internal compass? One of the tools that I think is very effective to help you identify what your internal compass is to develop your own personal mission statement. Institutions and organizations have mission statements of their own, and these mission statements help the organization focus and guide their efforts. It's possible to develop a personal mission statement as well with the same goal of focusing and guiding your efforts. Effective personal mission statements can affirm the creator's intrinsic motivation and serve as an internal compass to help you make informed career choices. Personal mission statements can imbue meaning to your work and can help you make strategic career choices, especially early in your career. So with this internal compass in mind, I would encourage you to take stock of your activities early in your career. For the most part, these activities can be divided into 3 main buckets. And those activities are things that you just absolutely have to do to be a good radiologist and a member of your community. Maybe it's something that your local community needs, that the Department of Radiology needs, or the section that you work in needs. You may have certain activities that you absolutely have to do in order to get promoted or to gain partnership in your practice. And the third bucket are the activities that you do because you absolutely love them, things that you are passionate about. With the creation of your with the creation of your personal mission statement, I believe that you can help really combine these buckets so that you can optimize your time in this orange zone where all of your activities overlap and can serve multiple functions at one time. And ideally, you can really grow that overlap so that you spend as much time as possible in this zone where your actual activities are contributing to all 3 of these buckets. Once you've identified this, this zone of flow, this area where your passions lie, I encourage you to pursue your passions with gusto. The more enthusiastic that you can be about the things that you love to do, the more buy-in you're going to get from the people around you. Maybe the things that you want to pursue, the niche that you've developed for yourself, will fill a need for your department. If not, go ahead and create the need. Fill a need that people didn't know existed. You may have to really encourage your partners and your colleagues to see your vision, but I believe it's entirely possible for us to create leadership positions for ourselves and to create the pathway, our career pathway that really fulfills our driving passions. So in summary, I hope that you'll be able to identify your passions, pursue your passions passionately, and fill a need or create your own niche. I look forward to having more discussions with you at the conclusion of this panel discussion.
Hello, my name is Pari Pandey. I'm a radiologist at Mass General Hospital, and the title of my talk is When Things Go Wrong. So here's the thing, things are going to go wrong the first few years of your practice, and they're going to go well in the first few years of your practice, and they're going to go wrong and well for the entirety of your practice. The key is that when things do go wrong, you learn from those experiences, so that you have an approach to making those circumstances ones that end up actually improving your practice as a radiologist and your way as a professional throughout your career. So here we're going to go over different vignettes of missed cases, rejected papers and grants, and of negative feedback, and we're going to discuss approaches to these circumstances. So you read a staging liver MRI for a patient with colorectal cancer. The patient undergoes resection of a segment 2-3 metastasis that you saw, but intraoperatively, the surgeon finds a second metastasis that you did not see. The surgeon resects it and lets one of your more senior colleagues know, who reviews the MRI and sees that you missed the second lesion. She does not see any other lesions. She lets you know about the miss. So this is so hard. It happens to all of us, and it just, every time it's going to be hard. But I think the key is to have an approach to deal with this when it happens. The first thing you want to do is take care of the patient. Make sure the patient incurs the least possible harms from your miss. The second thing you want to do is think about your interaction with your colleague. Remember that it's not easy to approach someone and tell them that they missed a finding. So you want to express appreciation that your colleague did so, and you want to make sure that you're not defensive or questioning your colleague's interpretation of the case during that interaction. Third, you really want to take care of yourself. Remember, this is not easy. So you want to make sure that you feel okay and that you can move on. Sometimes this just means taking a few minutes to reflect on the case and then you feel fine. Other times, and this is completely okay, you may need assurance from your colleagues and mentors that you're doing fine. And I would really encourage you in those cases to seek that kind of assurance from your colleagues and mentors. Finally, if you feel comfortable, share your mistakes and share your misses with your colleagues. The best radiologists that I know are really open about sharing their misses, and they learn from themselves and they learn from other people continuously. And so if you're able to do that, and if you're able to contribute to that peer learning community, I think it will help you as a radiologist enormously. So you have worked very hard on a career development grant proposal. You have published preliminary data, found mentors and collaborators, been nominated by your chair, and revised your ideas and words many times over. You've worked very hard on a research project. You've obtained IRB approval, found 2 colleagues to review cases, engaged a statistician, and written up your results. Your paper is reviewed. Your grant is not funded. Your paper is rejected. All right, so if you're like most of us, this is how you feel. You feel pretty upset. So it's helpful to have an approach as to how to deal with this. So the first thing that you want to think about is yourself. And the reason is because if you're like most people, as I mentioned, you're going to be pretty upset in this circumstance. And you need to sort of figure out a way to handle that. So this is a rule that my mentor shared with me early on in my career. It's the 24-hour rule. If no immediate action is necessary and you're upset, wait at least 24 hours before you do anything. Things will seem much clearer in 24 hours. So if you need support from your mentors and colleagues, by all means, contact them, let them know how you're feeling, and ask for their support. But do not, under any circumstance, reach out to a journal or a grant agency in that first day after you've received their rejection. Next, you have to make a plan. Remember that your chair and your colleagues understand that you're not going to get grants and papers accepted every time. The way to get grants and papers accepted is to submit them. And that sounds very sort of obvious, but I think it's an important thing to say. I always think of the analogy to basketball. You can't make shots unless you take shots. And so it's really important to constantly be taking shots. You want to be a good shot, but you're not going to make baskets unless you take shots. And so you have to keep trying. So your chair and your colleagues are going to be looking for you to keep trying. Where they're going to be disappointed is if you don't have a plan to revise and resubmit that work. And then share your plan with your colleagues. Finally, like in the peer learning circumstance, I'd really encourage you to share your academic and research successes and failures with a peer community. When you do so, you will all get better within your department or practice at submitting papers and at submitting grants. So your supervisor asks to speak with you. They convey that you are doing well, but a few of your colleagues and referring physicians have noted that your reports are a bit long. They give you a few suggestions on how you might shorten your reports. So negative feedback is never easy, and we want to be prepared for how to deal with it when it happens. First, think about yourself and remember the 24-hour rule. So if you find that the type of feedback that you're receiving really upsets you, definitely wait a little bit before you respond to it. Again, it helps to have a little time passed after that initial sting where you can think more clearly about what the person giving you the feedback was trying to convey and what you can do about it. Then you want to revise your plan. You want to be responsive as possible to negative feedback. So think about what you can do in this case to shorten your reports and make changes. Finally, make sure that you engage your supervisor and your colleague in this process. And by that I mean, when you make the changes, make sure that you circle back to your supervisor who gave you the feedback and ask them for further feedback. Did it make a difference? Have they had any more feedback from referring physicians? Again, you want to be as responsive as possible to the different kinds of feedback that you are getting. When a supervisor thinks about the kind of individual that they want on their team, they're not going to ask for everybody to be perfect at everything at the outset, but what they really do value is people who are responsive to feedback. So you want to be one of those people. And then finally, again, if you feel comfortable, share your experiences. If you have peers within your group, share the things that you do well and the things that you might not do so well so that you can learn from each other. In terms of take-home points, remember that successful people are not unfailing. They just try many times and learn from their mistakes. Remember the 24-hour rule and share your experiences and be part of a community that's humble and wants to improve. Everyone who is successful will, if they're being honest, tell you that they've failed so many times. And for most people, it's those failures that really shape almost more than anything who they've become. Thank you so much for sharing this time with me. You're going to do great in the first years of your career. Don't ever hesitate to reach out to me if you need anything. Take care.
Good evening, everyone. My name is Joanna Fair. I am a professor and Vice Chair of Academic Affairs in the Department of Radiology at the University of New Mexico, and also Senior Associate Dean of Graduate Medical Education there. And I'm going to share with you a little bit tonight my perspective on how to be successful in your first year, both from things that I did and things that I didn't do that I wish I had done when I started in practice. So most of this is really tips about what you might be thinking about before you start, as well as a few tips about your early days on the job. So when I think back about my time as a new assistant professor, I had done my residency training in radiology at UNM, left for a year to do nuclear medicine, and already knew that I was coming back. I had even signed on the dotted line before I left that I was going to take a job there. And the thing that I didn't do is ask exactly what they might need when I returned. So I knew that I was going to do nuclear medicine. I knew that I was going to do general radiology call. But what I didn't know is that they actually also needed someone to help in pediatric radiology. And this was a little terrifying when I came back on my first day and found out that that was going to be part of my job. Fortunately, we have wonderful pediatric radiologists who helped me through that time for sure, which was great. But had I known that that was going to be a need and had I asked, I would have spent some time during fellowship potentially shadowing with the peds radiologists at my fellowship so that I would have felt more prepared when I started. The other thing that I didn't do that I would suggest you think about is moonlighting during fellowship, if possible, if there are opportunities and as time permits. When I went to do my fellowship, because I was in an accredited training program, I actually only got a training license. And by the time I realized that there were moonlighting opportunities, it was really too late for me to go through the process to apply for a full license and take those opportunities. And when I came back to my practice at UNM, I realized that I'd spent the whole year looking only at PET CTs without contrast, and I had not seen contrast in a year. And so it was definitely a shock to the system to see PECTs and a bunch of trauma CTs and all of that. And so if I could have done it differently, I might have really been more aggressive about trying to pursue moonlighting opportunities during fellowship so that I would have felt more confident on my first day back on the job. The other thing that I really lucked into that I suggest you look for when you start out is having a mentor or potentially even a sponsor that's going to be able to shepherd you through those early times. I was very fortunate to have Dr. Mike Hartshorn, my nuclear medicine colleague, and one of the things that he really did for me in that sponsorship way was get me connected with early opportunities to advance my career. So I wound up serving as the resident representative on the Nuclear Medicine Review Committee. He set me up as an ABR oral board examiner. He was offered to give a talk at the National Nuclear Medicine meeting. And he said, well, I'm not going to go this year, but really you should have Joanna give that talk. And he actually helped me with it and gave me slides, and also helped get me connected with our regional nuclear medicine society. Why does this matter in terms of you being able to help your practice originally is that when I started out, I was able to forge these connections with other people throughout the nuclear medicine community who are still friends and colleagues of mine today. I learned a lot from all of these experiences that I was able to then bring back to the institution. And then the last thing that I suggest is that you should not be afraid to ask for help. You will learn about the culture and climate at your particular practice. I was very fortunate to have one where all of my colleagues are very helpful to me when I need help. And the reason that this makes you invaluable is, one, you are role modeling for your other colleagues, for residents and fellows, how to be a part of a team and how to help each other out. And also, I think that this really helps you avoid the waffle. So a lot of times I would call my colleagues because I just wasn't quite confident about something that I was looking at. And I could have said, not really sure, got a follow-up, more imaging, et cetera. And instead, it really helped me be more definitive about some of the diagnoses and recommendations I made by talking to an MSK colleague or a chest colleague or a body imaging colleague about something unusual that I was seeing on a PET CT. And I think it very importantly then helps develop a culture within your practice of being able to help each other out if you are willing to role model that for others. So I think asking for help is oddly a good way to help make yourself be invaluable. So in short, my tips are find out what your practice needs before you start, consider moonlighting during fellowship to help keep your skills up. Look for a mentor or even a sponsor at your new job so that you can help grow in your professional career and be able to bring the things that you learn back to your institution. And don't be afraid to ask for help. Looking forward to talking with you all in the panel.
I'm Lucy Spoluto. I'm a radiologist at Vanderbilt University Medical Center, and I also hold an appointment at the VA Tennessee Valley Healthcare System. Thank you so much to the American College of Radiology for inviting me to be a part of this panel at the 2021 Radiology Leadership Institute Resident and Young Physician Leadership Program. I'm really looking forward to speaking on the panel with the other panelists after the speakers' talks. I thought I'd focus the next few minutes talking about transitions in practice. I remember that this is something that caused me a lot of anxiety when I was earlier in my career, and I thought I'd share some of the transitions that I've gone through in my practice and hope that some of this experience might be able to help you as you navigate some of these transitions in your career. I have no relevant disclosures. I began my medical journey at the University of Virginia School of Medicine as part of the class of 2006. This was the first class at the University of Virginia School of Medicine that was more than half women, which is very exciting. That's me circled up there in the red circle, towards the back row. I was the only woman in my class that decided to go into radiology. And so when I decided to pursue a radiology residency, I went on to this residency at Brown University in Providence, Rhode Island. After my residency, I did a women's imaging fellowship at Vanderbilt University Medical Center. And after I did my residency, that's really when I came on really the biggest transition in my early career. And I think that first big transition is moving from training to actual practice. And I think this is a big change. You're moving from really a big safety net of having someone who reads most of your studies with you, always having someone there to answer your questions, to becoming an independent practitioner, making all your own decisions, sometimes not having someone there as backup to help you make a decision, being put in a position to mentor and teach younger residents and fellows. And those are all big changes from being a trainee yourself. When I made this first choice of what I wanted to do after completing training, a lot of different factors went into this decision. One was geography. Where in the country did I want to be? And I think this is something that plays into most people's decisions. Another was what sort of support tools and clinical opportunities did the practices I was looking at have? Did I want to go into a private practice or an academic practice? Would I be able to subspecialize, or would I need to read all general studies? If I wanted to do research, was the infrastructure available? And another big piece that went into my decision-making was my family. Would this be a good choice for my family geographically? Would it be a good choice for my family with work-life balance, being able to spend time with them? And so I kind of weighed all those factors, and I decided to go into a private practice immediately following my training. And I was in private practice in Nashville for about 2 years. And after a little bit of time in private practice, I decided that I really wanted to return to academia. I was a little more interested in research and teaching. And so I made the decision at that time to transition. And I think that this is another big decision if you're going to change jobs into your career. Whether it's a few years in or several years down the road. And that transition might be from private practice to academics, from academics to private practice, from one academic institution to another, or another private practice to another. And a lot of things go into this decision also. Again, some of the things I mentioned for how I decided to take my first job. Definitely geography and what the particulars of the job are, and if it's a good fit for your family. But I had to make a much bigger pros and cons list at this point, and I had to make it a little more into the future. What did I want my career to look like in 5 years or 10 years? How did I want to make my mark on radiology, and what practice was going to allow me to do that? And that's why I decided to come back to academics. When I first started academics, I was predominantly doing clinical work, and I kind of decided I wanted to get more into research. I was very interested in diversity and inclusion and health equity, and realized I didn't have the tools I needed. And I think as you advance in your career, that's an important question to ask yourself. Does your current position and institution offer you the tools you need to be successful? I gave the example of my son making this little birdhouse at a Home Depot Saturday morning kids workshop. To make something as simple as this little birdhouse, you need the right tools: a hammer, a screwdriver. You need safety tools like these safety glasses. I think without the right tools and without a good safety net, it's really hard to sometimes advance your career the way you want to. So I decided to go back and get a little bit of extra training. I did the VA Quality Scholars Program to get some leadership training and research training, and did a Master's of Public Health degree. And I think it's totally worth going back, assessing what skills you need to get to where you want to go continuously throughout your career, and not being afraid to find the resources to put those extra tools into your tool belt to move your career forward. Other big transitions can be taking on leadership positions, whether this is earlier in your career or later in your career, whether these are taking on educational leadership positions or other departmental leadership positions, moving to vice chair or chair position, moving to a position of leadership outside your department, potentially within a cancer center, or a dean level position with your institution. And again, assessing what tools you need to take on that leadership position, and not being afraid to find a way to put those tools in your tool belt. So thank you so much for taking the time to listen to a little bit of my career path. I look forward to taking your questions at the panel. And please don't hesitate to reach out to me anytime. You can email me, call me, reach out on Twitter. I really look forward to hearing from everyone in the audience. Thank you again.
Great. Thank you very much to all of our speakers for excellent presentations. We will now begin the Q&A session with all of our speakers for the panel. If I can ask all of our speakers to turn on their cameras. All right, and we have a number of questions coming in the Q&A box here. I'll just start with one question that we had earlier, and this is for Dr. Pandari Pandey. You talked a little bit about feedback and handling feedback. What do you do if one doesn't agree with a negative feedback that has been given? How do you handle that gracefully?
So that's a great question. I think in the beginning of your career, when you feel that the feedback you're given isn't fair, you're also trying to understand the context of your practice as well. You're trying to get to know the people, you're trying to get to know the circumstance. And so in that setting, again, the two things that I advise sort of consistently in these scenarios are, first, wait a little bit. Always wait a little bit. 24 hours. If you find yourself upset or disagreeing, wait a little bit. And then if you still find yourself disagreeing with the feedback you're given, consult some colleagues and mentors, even if they're not within your practice, somebody from your residency, consult them to see where, to give yourself some perspective. I know that it can be hard in some circumstances. I think it is important to go back and challenge some of the feedback that's given if it's not fair. But I think it's helpful to come in to that conversation with a little perspective from friends and colleagues before you go in, particularly at the beginning.
Thank you for that. Our next question comes from Amanda Batten, and it's focused more on private practice. What is the best way to adjust to the speed of private practice transitioning from residency? So I'll let you guys decide who wants to answer.
I can start. So when I finished, I went directly from training into private practice. I was in private practice for a few years before coming back to academics, and it can be overwhelming. It's a very different atmosphere to leave academic training and go to private practice. I think what you have to understand, you have to trust that you've been well trained. You have to know that you always have a safety net. I tell all of our trainees when they leave, you can call me anytime, hopefully about something breast related. I don't remember all the other stuff quite as well now. But you always have that safety net of people to ask. And also you can ask your colleagues questions too. But if you trust your skills, then you'll be able to read your studies. You'll improve, or not improve, but you'll improve your efficiency over time. It also takes time. It's not just comfort reading the studies and speed of reading studies, but sometimes you have to get to know a whole new PACS system and a whole new dictation system. And so just know that the first few days to weeks to maybe even months may be a little bit, you may not be as efficient as you're used to being. It takes a little bit of time, but just knowing that you're well trained, trusting yourself and your safety net of colleagues, and knowing that you will sort of get more efficient over time, and then it'll just seem natural to work in the higher speed environment.
Thank you for that answer. And the next question is for Dr. Fair. Dr. Fair, you mentioned in your presentation mentorship and sponsorship, and one of our attendees is asking, what is the difference between a mentor and a sponsor?
That's a great question. And sometimes people function as both. And so I would say that Mike Hartshorn was both to me. But a mentor is someone who is more an advisor. You can have advisors, whether it's in regards to your practice or your research or anything else along those lines. You go to them to discuss cases or to ask about your career direction. A sponsor is someone who really advocates for you to have an opportunity to advance your career. So I would say as a mentor, Mike Hartshorn would take my calls, and I would say, hey, there's something weird going on this VQ scan. Can I talk to you about it? Or what do you think about what I should be doing? As a sponsor, he would say, hey, Joanna, here's this opportunity, and I'm going to put you forward for this so that you can advance your career. So he was actually both to me, but it tends to be a little easier to find mentors than sponsors.
And just have one thing, I heard someone explain it really nicely once. They said, a mentor is someone who has knowledge and will share it with you. And a sponsor is someone who has power and will use it for you.
That's really great insight. Thank you for that. I'm going to take the next question from Mohammed Hussein, who asks, when making decisions together, How can you make sure your opinion or input is being heard or appreciated?
I can take a stab at that. And I'm going to answer this thinking that the question is referring to making decisions together with a colleague and asking for advice. I think that sometimes when you're very early, it's hard to have a two-way, and you maybe will rely mostly on what your colleague says. But as we've already mentioned, you really have to trust your training and trust your instincts. And if you feel differently about something, approach it with thoughtful questioning and an open discussion, trying to minimize any judgment inherent in the words that you're using. And trying to foster a two-way conversation, and really trusting your instincts and trusting your training to make sure that you're doing what you feel is right, either for your own career development or patient care, depending on the perspective of this dual shared decision making you're discussing.
Thank you for that answer. Our next question is coming from Lola Olayedini, and she's asking about negotiation specifically. She asked, how did you negotiate your first job offer? Did you just take what was offered? And if you didn't stay at your first job, how did you know it was time to leave?
I will say I didn't negotiate well. I feel like I've learned a lot more about negotiation in the past few years. So I kind of tried to negotiate. I had a lawyer look at my contract, and there were a few little things that I asked them, and they basically said, like, no, this is the contract, like, take it or leave it. And I took it, and it was fine. There was nothing too bad in it. But I think ask a lot of people, ask other people who have gone out into practice recently, what was in their contract. If you see something that stands out to you, take a closer look at it, ask faculty for advice. But don't be afraid to ask. The worst that happens is if you ask for something to be changed in the contract, or for a higher salary, or for, you don't want to take call, you want to negotiate a different way to take call, ask. The worst that happens is somebody says no. The best that happens is they're like, you're right, we should have considered that. So I wished I'd asked more questions and been firmer in my first negotiations.
I think we can all attest to that. But I'm going to move on to the next question, which actually comes from one of our anonymous attendees. I just want to remind everyone you can ask anonymous questions, so feel free to do that. This is focused for Dr. Fair, and the question was, do you specifically need a full license, or can you use a trainee license when you're trying to moonlight?
Generally speaking, any sort of moonlighting that's external to your institution, or where you are functioning as an attending physician without supervision, requires a full license. A training license means that you have to have supervision. And so the only reason I'm being a little vague is because some programs offer opportunities for internal moonlighting to pick up extra shifts as a fellow, for example, that they might pay you for, that still have attending physician supervision. And so it's like an internal thing that might be paid. But if you want to accept a job where you're functioning as an attending radiologist, then you're going to need a full license. And those usually can take more time and expense to obtain.
Thank you. And our next question is for Dr. Robbins. So Dr. Robbins, you talked about defining your personal mission statement and really trying to fill a need or creating a niche in your first few years. Can you talk a little bit more about how do you refine your mission statement, and how often do you have to revisit it in your first few years of practice? For example, for yourself, how often did you redefine your mission statement when you started?
Yeah, I think that's a really important question, and it's an important point that I think the mission statement is something that deserves constant refinement. I think that at the very least, everyone should think about what they're doing and where they're going at least once a year. For faculty, we have our annual faculty development process where every year we think about what we've accomplished for the year, what we want to do for the upcoming year, what resources we might need. And that's a really great time to reflect on, are you doing the things that are really driving your passions? So I would encourage, regardless of your career stage, whether you're still a resident, whether you're early in your career, whether you're middle of your career, that an annual reflection, at least an annual reflection on your personal mission is really what's important.
Okay, I'm gonna address the next question first to Dr. Spaluto, but I think anyone could answer this as well. This comes from an anonymous attendee. In academic practices, what successful strategies have you seen employed to help even out workload among slow versus fast faculty readers? I plan to go into academics, and as one of the slower readers, I worry people who are able to read many more cases than me will become resentful in the future. How do you prevent this?
So definitely a challenge and a good question and insightful to sort of recognize what could potentially be a problem. Some of it depends on how your organization handles or rewards different contributions to the department's mission. So, and that's a question, if it's something that you're concerned about, that would definitely be something to ask in an interview or to review with your contract. So I can say in my department, the RVUs, or the relative value units, and that's something you'll hear more about if it's not something you know about yet, is sort of each study you read has a relative value unit, so they can track how many you read. And there are some practices that heavily compensate based on the number of RVUs that you produce or read. So in my department, that's a very, very small part of what we do. We're all sort of paid our salary, and then we get a bonus at the end of the year, and a very small part of that bonus is tied to an RVU. There are some private practices where a very large portion of your salary can be tied to that RVU. And so I think if you're interested in academics, that's a discussion to have with the chair or whoever is recruiting you, to say, you know, these are all of the things that I can bring to the department. I really want to be in academia because I love to teach, or I'm very interested in research, or I want to start a women in radiology program for you, or I want to start a wellness program, or whatever it might be that you are contributing uniquely to your department that you want to be recognized and rewarded appropriately for that. While there may be some people who are contributing more by producing more clinical work, you may be producing more other things for the department. And so I think it's just important for you to align yourself with an organization that has similar values and recognizes that you're offering more than clinical RVU production to the department.
Thank you for that. And I think our next question is a very important one. I think many of you mentioned that during your first few years of practice, you sought some additional training, be it MPH, and the question here is about pursuing an MS, MPH, MBA, or other career development programs. I know many of you have done the GE LEAD program. How do you go about asking your division chief or department chair to allow you to do those programs?
So I can take a stab at this. I know that there are lots of, everybody here has had has been involved in those programs. So I did an MPH degree. That's what the foundation of my research ended up being, in something called decision science, kind of comparative effectiveness, clinical effectiveness. I did it after my residency, kind of during my fellowship. You can also do it, people do MBAs and MPH degrees often after their faculty. I would say that the big thing that a department is going to be looking for, whether you do it, coming into your fellowship, coming into your faculty position, or in your faculty position, is what are you going to do with that degree? So you want to make sure that when you're pitching this, or when you're thinking about this, and pitching it to your supervisors and your colleagues, your colleagues who are going to also be working, potentially doing more clinical work while you're away. What is it that you're going to bring back? And you want to be sort of very clear about that. It's not about your career and you're going here and it's all about you. You don't want to be like that. It should be about what you're bringing, yes, to yourself, but also to your department and to your community and to your patients. And I think that's the framework with which you look at it. And you can do that through getting a lot of training, leadership training, and additional degrees. Both can achieve those goals.
Okay. Our next question. So you may not realize that all of our speakers today are actually females. We kind of did that on purpose. And there's a question that comes specifically asking about women as women leaders in radiology. So I'd like to address this to the panel. I know, Dr. Spoluto, that you can speak to this because you have so much experience, but I'd love to hear from a couple of the other panelists. The question is, what are specific policies that have supported your careers and that residents should look for in their first job, such as academic promotion requirements, family leave, part-time, et cetera?
Well, thanks. Great question. And this is a great panel I'm so pleased to be a part of. And I think, again, this is looking to the organization before you join it, getting a feel for what the culture of the organization is, what the organization values, whether that's through people you've met there or going to visit. A lot of times on a visit, you can kind of get a feel for what the culture of a place is and seeing if it aligns with what your culture and your values are. And if it does or doesn't, it may not be a good fit for you, but it's also something that you can work towards driving change for. If you're in an institution where you see things that maybe could be improved, then you can talk with other leaders who have been able to change things in their institution, start a program to change, start suggesting that, maybe we should have better family leave policies, or suggest that if we offered part-time, that maybe that would help to retain more faculty members or improve faculty wellness. So many institutions, thankfully, have shifted to this more wellness-focused culture, and a lot of that has to do with some of the leaders who are on this panel, and the ACR Commission for Women and Diversity has driven a lot of national change in this area, and the AAWR, the American Association for Women in Radiology, drives a lot of change in this area. So there are a lot of national societies that are pushing these policies that are supportive of the needs of not only women in radiology, but really everyone in radiology. These family leave and part-time opportunities, while a lot of times do help women in radiology, help all people in radiology. We all have people we need to take care of. We all need to take care of ourselves too. So I think that, these national organizations have pushed this to the forefront and have started to drive change. A lot of organizations have their own groups that are driving this change. And if this is something that's important to you, you can definitely get involved either locally or nationally in those efforts. But I do think it's important to, again, sort of assess the organization you're going to be joining and see if you align well with the values.
I can think of a few specifics, definitely looking at family leave policies. When I started, there wasn't any for the first year of practice, and I showed up pregnant, whoops. So my department kind of pushed things around and we made it work out, and they took care of me, but the institution didn't at the time. Now it's all better. There's 8 weeks for everybody, but it wasn't at the beginning. We also have a flex track, so you can be hired in on the flex track, and you have 3 years to decide whether to go with clinician educator or tenure track, and you can either count the 3 years or not count the 3 years towards your clock. And so you can go up for promotion after your 5 to 6 year window, or you can wait longer, and that's very helpful. My department also allowed me to work 80% time for the first several years when my kids were little. And so I took 1 day off a week to hang out with them. And I discussed that, negotiated that upfront before I started. So these are the kinds of things that you can ask about and get feelers for. And if you get a lot of whether you're male or female, these may be things that you want. If you get a lot of pushback about them, then you have to think about whether that's a place that you want to be. So
I'll just add one quick thing to that. something that I think both Joanna and Lucy mentioned is that when it comes to culture, it's important to talk to people within the practice and see what their journey has been, has been like. I think that's extremely helpful, because there can be different policies and different rules, and some of them are favorable and some of them are not favorable. But even with favorable policies, what you really want to know is what is the support like, and are there people who can help you along the way?
Thank you for those insightful answers. The next question is about, I guess, a feeling that many experience when they start as new attendings, and it's about imposter syndrome. I think as people start in their first attending jobs, they feel a little bit of imposter syndrome. What strategies can you offer for people to combat that feeling?
I'd like to take this one to start, if that's okay. I didn't know about imposter syndrome for many years. Like, I probably went through the first 5 years of my career not having a name for the thing that I felt for a lot of my life. So knowing about imposter syndrome, I think, is very helpful in being able to name it and identify it, so that you can maybe take a step aside and turn your head around and look at this and say, oh, this is imposter syndrome. I'm going to acknowledge that sensation, and I'm going to remind myself that I'm good enough, and I deserve this, and I'm making the right choice here, and try to move forward and kind of do some self-talk. And sometimes you need your friends in the evening on your porch to remind yourself that you're good enough, and that you're really deserving of the things that you have and have accomplished. But that first step is to just have a name for it and know what it is. So you all are so much further ahead than I ever was at the early stage of my career.
Okay, I think we have time for one more question. I just want to let everyone know all the questions you have submitted, whether anonymous or not, we're going to be sending to our panelists. So you will get responses. So if we haven't gotten to your questions, or you thought of a question and didn't get to send it, please do so. We will make sure that your questions get answered. But the next one comes from Michael Hood. And I'd like Dr. Fair to maybe start this. How do you overcome institutional inertia when trying to bring new ideas or workflows to the table?
It is challenging, right? I think you wind up yourself having to put a lot of effort into it. If it's important to you, then you'll have to bring the idea forward and build the support for it to be able to move it forward. But I think part of it then is finding, if you really are alone and nobody else is interested in it, it may be difficult. So kind of gathering people of similar mind to work with you on it together. And then for me, it's really about the data, the why, why is this important, and getting people on board with that. If you're just like, I think we need this thing and nobody else thinks that, it's really tough. But if you need it and there's a clear why and data to support it, I think that can help you overcome the inertia.
Anyone else want to add any last points on this? That was an excellent point. Thank you.
I think one of the things that I agree with everything Joanna said. One of the things I would add is that, like, you want to vet your idea, but remember that all of these, things like as basic as like what we take for granted now, PACs. When before digital PACs, a bunch of people were like, oh my gosh, why would you want to change from film to PACs? And so have confidence in yourself. Like, the best ideas come from all over the place. And so have confidence in yourself, have confidence in your leaders, make appointments with people that you wouldn't think you would want to necessarily, don't make assumptions about who a chair would want to hear an idea from. I think leaders want to hear ideas from all kinds of people, and just go for it. I think, if you have an out of the box idea, sometimes those are the best ideas. Don't be afraid of being rejected. But it's always a great idea to just go for it.
Thank you. And I don't know if you guys are all paying attention to the chat feature. Dr. McGinty actually just sent a message to everyone. Her first PACS proposal got completely shut down. Well, that was in the mid-90s. But with that, we're going to take a quick break. We will restart at 8:05 and actually have our next session with Dr. McGinty. So we look forward to seeing you all, or having, I guess, you see us at 8:05.
All right, welcome back to our second session for this evening. And again, thank you to our panelists from the first session for such an insightful discussion. For the second session today, we'll be hearing from two speakers on two very important topics, becoming a change agent, the art of influence, and that will be followed by transitioning from learners to leaders, lessons in lateral leadership. These talks will be given by Dr. Geraldine Mcginty and Dr. Shlomit Goldberg-Stein, respectively. As a reminder, there will be a Q&A session following the two talks, where you will have a chance to ask Dr. McGinty and Dr. Stein your questions. So please submit your questions using the Q&A button at the bottom of your Zoom screen, as we did in the first session. Before I turn it over to our speakers, I'll just start with a few introductions. Dr. Geraldine Mcginty really needs no introduction, but she did her medical training in Ireland at the National University, and then came to the US for residency at the University of Pittsburgh, where she was chief resident. Her fellowship was in women's imaging at the Massachusetts General Hospital, and while working at Montefiore Medical Center in the Bronx, she completed an MBA at Columbia University. She is an internationally recognized expert in imaging economics. She has served as advisor to the CPT editorial panel, the JCO, and the National Quality Forum. She was chair of the American College of Radiology's Commission on Economics and was the radiology member of the AMA's Relative Value Update Committee from 2012 to 2016. In May 2018, she was elected as the chair of the ACR's Board of Chancellors, the first woman to hold this office. She was, until 2013, managing partner of a 70-physician multi-specialty medical group on Long Island. And in 2014, she joined the faculty at Cornell in New York City. As well as her clinical practice there, she serves as Chief Strategy Officer and Chief Contracting Officer for the Weill Cornell Physician Organization. She was recently appointed as Senior Associate Dean for Clinical Affairs. Her published work has focused on payment models for imaging, most recently bundled payment for breast cancer screening. Recently, she has focused on the impact of artificial intelligence on medical imaging and has spoken at the Turing Institute and to the WHO focus group on AI in healthcare on this topic. In 2015, she was voted radiology's most effective educator by the readers of Aunt Minnie, and she has currently more than 15,000 followers on Twitter. Dr. Shlomit Goldberg-Stein. Dr. Stein is a musculoskeletal radiologist at Northwell Health in New York. She has previously served as the system-level director of operational improvement at Montefiore Medical Center, Albert Einstein College of Medicine. She has also served as medical director of Gun Hill MRI Advanced Imaging Center and Medical Arts Pavilion. Dr. Stein has coached multiple teams in performance improvement, focusing on increasing operational efficiency and patient access. Dr. Stein has also served as director of report quality and co-chair of the Structured Reporting Committee, which optimizes and standardizes radiology reporting and recommendations at Montefiore. Dr. Stein's clinical interests are in musculoskeletal MRI, image-guided bone and soft tissue biopsy, and image-guided therapeutic steroid injections. And she has previously served in the role of director of musculoskeletal intervention at Montefiore Einstein. Dr. Stein received her BA degree in political science from Barnard College of Columbia University, summa cum laude and Phi Beta Kappa. She completed her residency in diagnostic radiology at Massachusetts General Hospital, where she was awarded the Wyman Award for Overall Excellence in Residency. Dr. Stein completed a fellowship in musculoskeletal imaging and intervention at MGH as well. Dr. Stein is currently co-chair in the Quality and Safety Committee of the New York State Radiological Society, and she was the recipient of the New York Röntgen Ray Service Award in 2018. She was co-recipient of a 2017 American College of Radiology Innovation Fund grant to develop educational modules on standardized reporting for liver lesions. Dr. Stein is a physician champion for peer learning, currently serves on the ACR Peer Learning Committee, and has co-developed a web-based feedback module for radiology technologist quality improvement. Dr. Stein is a graduate of the SCAR GE Healthcare Lead Program, Montefiore's Performance Improvement Fellowship, and Montefiore's Physician Leadership Fellowship. Dr. McGinty and Dr. Stein, thank you for joining us today. I will now turn it over to you for the presentations.
Good evening, and I'm delighted to be with you for this session. I'm going to keep my remarks reasonably short because I'm looking forward to a robust discussion. There are some terrific and really important topics covered in this evening's event. My name is Geraldine Mcginty. I'm a radiologist at Weill Cornell Medicine in New York City and have spent a lot of my professional career as a volunteer with the college, including a term as board chair and president, which ended this past May. And I'm delighted to see you all here this evening and thinking about your future careers and building your influence. So let's get started. And when we think about influence, it's a term that has perhaps acquired a negative connotation. You know, the word influencer, I think these days typically suggests, you know, the kind of Instagram influencer. This is Cristiano Ronaldo. I'm not a soccer expert or fan, but, you know, it is not insignificant that he has more than 300 million followers. So there's no doubt that while we might perhaps look down on some of these social media influencers, that they really do have an impact. And we'll come back to, you know, why this can be a good or bad thing. But we're not really going to talk about social media. We're really going to talk about influence in the professional sense and what it is that you can do in your organization to build influence. And why are we talking about this? Well, I love this. It might look like a biological drawing. It's actually the organizational chart of the New York and Erie Railroad. And each of those little dots that look like perhaps, you know, it looks like a little bit of breast architecture meets lung architecture. But this was a time, and obviously we're talking sort of latter part of the 19th century, where organizations could have a very centrally controlled process and operational culture and organizational culture. Think about it. Communication was very manageable. And you know, you could make sure that each of these little dots was operating in a way that the central organization decreed. And there was a sort of an acceptance of this very rigid organizational hierarchy. And I think in medicine, we have possibly held on to some of those rigid organizational hierarchies longer than in the business world. But there's no doubt that even in healthcare organizations now, we're seeing hierarchies, tables of organization that look much more like this. People are reporting to multiple different constituencies and stakeholders. With evaluation tools like 360 reviews, even though it's always important what it is that our boss thinks of us, it's in some organizations equally important what our direct reports and peers think of us. And, you know, in complex organizations, I'm thinking about my own, where I work for a medical school, I attend at a hospital, and we also have a large community of physicians and other stakeholders. There's no doubt that, you know, there are a number of fora and a number of ways in which I, as a academic and business leader in the organization, have to build influence. And this is something we're going to work through in terms of thinking about how you can start to build influence, no matter where you are in the organization, because obviously you want to be effective where you are. But I think most of you are here because you also want to make sure that you have a path to success and growth in your organization. So, you know, this topic can feel particularly applicable when we're perhaps at the beginning of our careers. We've been given some responsibility. Maybe it's being chief resident, maybe it's being division director, maybe it's a role on a committee for your organization or for the ACR. But this term middle manager just doesn't necessarily feel like something aspirational, right? Even though I like to say that everyone has a boss, even the Pope has a boss. It can feel, as somebody who's not at the, in the C-suite or in the executive level of an organization, as if, you're being tasked with perhaps implementing policies that you haven't had a hand in making. You are not in the decision making in the rooms where the decisions are being made, and you can often feel as if perhaps you're not able to give meaningful input, and you're not necessarily in a position where you have autonomy and control. So, recognizing that, I think, it's important to think about where you have opportunities to change some of those things. So a lot of times when people come to me and ask me about, getting involved with the ACR or thinking about a career path, I ask them, what are the decisions you've seen made in your organization that you'd like to have been part of? Even if they're decisions that you agree with and support, what are the things that resonate with you in terms of, I would like to bring my expertise and my input to those. And certainly if there are decisions you haven't agreed with and you haven't felt like, they've captured what's best for the organization. But I do think there's also work, and I use this in a great course that I get to teach for the RLI called Maximizing Your Influence. There's no doubt that middle managers or people at the levels of management in the organization, especially those who are in direct sort of operational management or leadership, those are critically important roles, because they are where, honestly, an organization can succeed or fail. C-suite leadership that doesn't understand the importance of connecting with people on the ground, people who are actually executing on the organizational vision and mission, that's a C-suite that probably isn't going to be as successful. So this is a role and this is a position in an organization where there's a lot of opportunity, but let's be clear, it can feel a little bit frustrating. So how can we find techniques and tactics to move past that? One important thing, I think, is to step back and think about who you are, think about who your organization is, and think about what is the particular situation at hand. So what do I mean by that? Well, if you've heard me speak, you may well have heard me reference this book, New Power, and it speaks to the fact that successful organizations are more and more going to have to really engage with their stakeholders and allow people the ability to be part of decisions, and not be so hierarchical. But the authors are clear, and that not every situation lends itself to those kinds of new power, crowdsourced, GoFundMe kind of decisions. And also that not everybody feels comfortable functioning in that way. So this is a completely unscientific quiz that they have on their New Power website. And it speaks to the fact that there are organizations that they call castles. So they'll talk about things like the National Security Agency, where you can't really open up their processes. There are real solid reasons for things being secret. I would argue that the ACR's role as a issuer of practice parameters, or as the issuer of the Journal of the American College of Radiology, has a requirement for old power rigor around science, around lack of bias, around process. So, there are things that are highly appropriate to be in a less participatory role, which again can feel like you're not able to penetrate them. In terms of the part of this grid which speaks to where we are interested in getting people to participate and opening up influence, think about some of the work that we've done at the ACR in terms of engaging our trainees like yourselves in, for example, the discussion around family leave for during residency. Those are processes where you really want to open up. This is as you will recall, there was a change related to the American Board of Medical Specialties, and it was really important that everyone's voice was heard and that we made sure that nobody felt intimidated. And I'm speaking specifically about the process at the ACR meeting last year. Nobody felt like they couldn't speak. So there are situations that require more structure, more rigor, less autonomy, and other situations which where we will be more successful if we open up. But then there's also who you are. And what this quiz allows you to do is find yourself on this grid. And I know that I am somebody who sits firmly in the place that I'm always interested in hearing more opinions. I'm always interested in the process by which we have a freewheeling discussion and then as a group we come to what we think is the best decision. But one of the things that I've had to learn as a leader is that you would be well advised to understand who are all the other people that you're dealing with, because to assume that their style is the same as your style means that you may well find yourself not supported in what you're trying to do. So really understanding what's the task at hand, who are the people I'm working with, and a lot of that then has to do with what's the culture of the organization in which I work. So the organization I work in, our dean has a very consensus-based style of decision-making, freely admits that. So that's a lot of how we look at big decisions. I've worked in other organizations which have been much more hierarchical. So, really read the room on what kind of organization you're in and where you will be most successful. And that may, in fact, predicate some of the decisions you make about your career or where you choose to make your volunteer efforts in the future. So match your style to the moment and the task at hand and the organization you're working in. Another thing I would suggest you do is look at who is influential in your organization and think about why. Look at who's already serving on committees, who is getting leadership roles, and think about where you see opportunities for yourself. Now, of course, when we have this discussion, and I think this cartoon speaks nicely to it, because we know whether it's in the profession of radiology, in academic leadership in medicine, in leadership in business in general, too often what we've seen is people are influential in organizations because they are a cultural, demographic match for those who are already in leadership. And we know that if you are coming into an organization or trying to break into leadership and you don't have that cultural match or demographic match, it is unfortunately much, much harder. So, here's where, the efforts that we've made in the college and the ACR to diversify our profession, whether it's through, our peer program to bring in students from underrepresented minorities and encourage them to choose radiology, so many efforts. This is why these are so critically important. This is why we see, so many organizations saying, look, if we keep doing things the same way and keep picking the same people for leadership, we're not going to make the best decisions because our leadership isn't going to be appropriately diverse. But, I think, there is the potential eventually that we will see organizations where we say to ourselves, this is not a place where I'll succeed. This is not a place where I can be influential, because, I think about earlier this year, Professor Nicole Hannah-Jones, who eventually turned down a tenured professorship at the University of North Carolina after a bruising tenure process, because she said, I feel like I'm not going to be supported and this is not going to be a place I can succeed. So, but still, I would say, take a look at, who is finding their way in leadership and, putting aside some of the challenges, just see what lessons you can learn from what committees they've served on, what are the things they've done during that path, and reach out and ask. People always tend to be very generous with their time. A key concept that I want to talk about, though, that is, I really think is a key skill and a key tool, and something that it's so easy not to spend enough time investing in, is this concept of social capital. And again, there are some sort of negative concepts, this whole sort of, who goes golfing with who, and who went to the same school. Okay, all I said before should apply to that too. But in terms of how we build influence in an organization, our ability to create social capital is critically important. So making connections. So, really adding time. And again, I know we have busy schedules, but finding time to network within your profession, within your organization, and specifically with people who you think are doing interesting work, who you think are in those rooms where those decisions are being made that you want to be part of. Building trust so that people are getting to know you. And there's research that shows that, unfortunately, those of us who are women, people of color, don't have the same automatic level of trust with senior leadership, sort of traditional senior leadership, that's people who, again, have that cultural and demographic match do. So, for some of us, that there has to be an additional level of relationship building and trust building. I wish that weren't the case, but it is the case. So, again, to go back to the fact that we're not just talking about managing up, we're talking about your peers, we're talking about, if you're in a position where you have a management responsibility, your team. It is by building social capital that you also foster cooperation, both at a peer level and from your team, that allows you to perform more successfully. So there's a lot more you can read. This article is actually quite old. It's from 2001, and it certainly predates any of the social media platforms that are so prevalent now. But I think it's well worth a read in terms of the tactical things that you can do to build your influence in an organization by building social capital. So a few takeaways in my last few minutes. Networking is so important. Everybody needs a robust professional network. And I say up, down, and around. So, people who are doing the job you want, people who are your peers. You never want to be going to someone with a problem and meeting them for the first time. And your team. Spend the time to really learn who your team are and, what are their professional goals, so they understand that you have their back. The next one's in capitals, because it's something I teach my business school class. It's something that, honestly, if a project hasn't gone well, I can often, I would say always, go back and say, did you spend enough time? You had a great idea. You thought it was going to work. Did you spend enough time asking everyone who is potentially going to be impacted by it, who might be interested in it, and who might think it's a terrible idea? Did you spend enough time engaging with those stakeholders to refine your idea, to build support for your idea? You can never do enough of that. So building influence is closely tied to that. Another one is really, and this goes back to the new power thing, reading your organization. What are the big issues in your organization? What is keeping your boss awake at night? For you to be influential in the organization, being seen to be part of tackling the big issues that are happening is going to be critically important. So this question of what is the problem you are trying to solve? So understanding what are the key issues of the day. When you do have a team that's reporting to you and you're working on a project, it can be tempting to focus on that one project. But I would say that I'm always looking for opportunities for our team with appropriate resources. Don't get me wrong, for us to expand what we do and expand our mandate. And then the last one shouldn't need explaining. Harry Truman's famous sign, "The buck stops here." As a team leader, the responsibility is yours for the team performance. And I think that for people to trust you, for people to see you as influential, they want to see you taking ownership of what your team is doing. And there is very little respect in our culture, I think, for people who are prepared to throw their teams under the bus.
So why does this matter? Well, let's look at a couple of examples, both positive and negative, from outside radiology. We'll start with Marcus Rashford, who is a soccer player, plays for Manchester United and the English national team. What he has done is leveraged his influence, leveraged his personal brand to really make change at a national level beyond soccer. He influenced the British government to continue free school meals through the summer vacation in 2020, recognizing the challenges that poor families like the one that he grew up in had with maintaining access to healthy food or even food at all for kids after the school year was over. So he's taking what he has built as a brand as a soccer player and amplifying that to do some real good. On the other hand, and this was a really telling article that showed that, as we see continued vaccine hesitancy and the continued dominance of misinformation in some communities, we can trace that back to a relatively small number of people who have been spreading that misinformation. So, a voice can go a long way, amplified correctly and through the very powerful channels that are available to us.
So I think I'll leave you with this from Margaret Mead, which is that it can sometimes feel when you're on a bird on that electrical wire that you don't have a voice, but through building social capital, stakeholder engagement, and strategic networking, you can certainly get a lot done. Thank you.
Good evening. My name is Shlomit Stein, and tonight I'm going to be talking to you about transitioning from learners to leaders and sharing some lessons in lateral leadership. As long as I can remember, my North Star has always been making this world a better place for people, caring for others, and improving their lives. Whether I'm reading cases or leading a team, this is always top of mind. Metaphorically speaking, your North Star is your personal mission statement. It's a fixed destination that you can depend on in your life as the world changes around you. Whether it's a new partnership you're forming or letting go of staff or starting a new clinical program, decisions will always trickle down from your North Star. This talk is about transitioning from being trainees from your learning years into leaders in radiology and healthcare. When you look toward the next phase of your career, try to be aware of what your North Star is and define your purpose. It may relate to research, educating the next generation of doctors, or population health as examples. We established our North Star to define a sense of purpose in our lives, to have a general direction that we're going in that can help guide our path. For me, it's patient care. The underserved minority patients deserve world-class care, and there are tremendous disparities in care and much room to improve on the patient experience across radiology and healthcare, and I've been focused on that. So I have a self-reflective question for you. Do you know what your North Star is and what direction you're going in? If you do, you can go ahead and jot it down now, maybe think about it for yourself, and if you don't, pay some attention to it as I go through this talk. As a leader, who you are and your authenticity is the most important thing. In addition to the North Star that will direct your path, it's important to know what your values are and what is truly important to you. As Roy Disney said, it's not hard to make decisions once you know what your values are. In the next 20 minutes, I'll share with you a few transformational times in my professional life to help you understand how your personal values, your principles, can help guide you on your leadership journey. I will go through my own leadership journey, picking a few highlights and share some things I did, including mistakes, but you'll always hear me go back to my values in a decision. So I want to ask you again, what's your North Star? And again, if you don't know, it can be your homework assignment. A bit then about my value system and its importance in leader decisions. I am uncompromising in my commitment to the practice of my religion. It grounds me and it keeps me focused on what's important. I'm going to share one lesson with you. The Talmud is the central text of rabbinic Judaism and the primary source of Jewish religious law. Therein is a concept debated in the Talmud, which is Bishvili nivra ha'olam, which roughly translates into the world was created for me. What exactly does this mean? How could it be that of the billions of people on earth, my personal existence is somehow essential to the purpose of the entire world? The answer is that each and every person has a unique set of strengths and talents, and therefore every individual is responsible to change the world. Often in life, the reason why people fail, leaders fail, to meet whatever personal obligations they have is because they mistakenly think that if I don't take care of my responsibilities, someone else will. Unfortunately, we fail to appreciate our own dispensable value and how much we can contribute as individuals. So we're taught to redirect ourselves from this misconception and declare that the world was created for me. There is, in fact, no one else who can perform the mission that has been set aside for me. This is an incredibly powerful concept that can take you very far. It's a leadership mindset and a value that has guided me in my leadership decisions. Your first faculty role is an opportunity to be seen as a significant contributor, someone who wants to solve problems and is willing to take risks, ask for help, do the work. When I arrived at Montefiore in 2012, fresh out of residency and fellowship here in Boston at MGH, I took a look at the unstructured reports we were putting out and was determined to improve on the quality of care delivered in the radiology department. I was committed to pursuing excellence for the department because I had seen it done better and wanted to spread that excellence to Montefiore. Of course, reports are the main work product in diagnostic radiology, and this was no small task for a junior attending, in particular because of the adaptive challenges required to put in templates in place of prose writing in a large multi-site department, largely inbred, where I was essentially a stranger. The challenge was, of course, convincing a large group of smart academic radiologists to change the way they work every day. And so change management skills were put to the test, and without any financial incentives, but with the help and support of my chair and a partner in this effort, and an amazing committee and team, after 2 years, the overhaul was completed. So the first principle is leaders take responsibility. They take ownership. They take responsibility for the overall betterment of the program or the organization. They consider needs beyond themselves and even beyond their own team. They never say, it's not my job. They work beyond their job description and absolutely hold themselves accountable for results. And when I look to hire people, and I've hired many, I look for this quality as well. I want to know, do you persevere beyond the point of pretty good? I want to work with those people, those with sky-high motivation. That's what I'm looking for in my team. Some of you may end up in a job that won't be perfect, where things are done a certain way because they always had been done that way. And if you want it to be better, it may be your opportunity to take the lead. A few years out of fellowship, I felt somewhat pigeonholed in my subspecialty and wanted to do something bigger, but I lacked the skills, resources, contacts to get started. I was busy clinically teaching, doing some clinical research, but I was existentially somewhat bored. Now, everyone gets their jollies from different things. When do you feel gold concordance and progress? Well, it's when your work is aligned with who you are. For me, I wanted to solve more complex problems at a higher level, at a larger scope, and with a larger impact on patient care. So I was looking for more complete engagement. What did I do? I reached out to someone I respected and only knew tangentially higher up in the organization outside of radiology and asked for a meeting. After a series of discussions, she eventually became a mentor of mine. At that first meeting, I told her I wanted to solve larger problems, and she gave me guidance on steps to take. And eventually I decided to pursue a year-long quality improvement fellowship, which she encouraged me to apply for. This fellowship gave me a skill set, tools I could use to apply Lean and Six Sigma methodology to healthcare, and really also an excuse to find a suitable final project for the course. In that project, I worked on improving access to pediatric MRIs with sedation, and I reached a vulnerable population with significant improvement in appointment wait times for these very sick children. The fellowship gave me the opportunity to build a skill set and lead a team through a successful workflow transformation with clinical impact, and I was hooked. All I wanted to do was more of that. Additionally, the fellowship got me connected to others in the hospital doing the work I was interested in doing, quality leaders and clinical leaders who would teach me more along the way. So principle number 2, and the lesson I learned, and this is practical advice, you should seek leadership training and professional development opportunities because leaders work to develop themselves. Leaders are lifetime learners. They seek out that training, they build networks, and they form a personal board of directors and a complement of mentors, coaches, and sponsors. After the QI course at Montefiore, I took another course at UMichigan in Lean and Six Sigma, and some of the people I met there were added to my list of mentors. And I realized later on, after formal leadership training, both at Montefiore in a physician leadership program and through GE SCARD's LEAD fellowship, that much I would have had done in the earlier years had been done somewhat by the seat of my pants in negotiation and change management. All of that could have benefited from training and skills practice even very early on. So there's really no book about how to get started. And the question you're going to ask yourself is, how can I leverage my strengths to get ahead? So take this as a lesson learned and consider how you plan to build your skill sets as you set out in your journey from learner to leader. Here's what else you need. This is a tactical approach. You need to build networks and go beyond your area of specialization, go into other departments, and build that personal board of directors. So what does that mean? Those are people that you surround yourself with that can give you advice on anything that comes up in your career, people from different paths and different areas of your life that you trust. And then there's mentors, coaches, and sponsors. A mentor is someone who talks with you about your career, your goals, your plans, and your aspirations. A coach is someone who talks at you as you try to perfect something very specific, and you may at some point wish to invest in your career and consider hiring your own coach. That has been very beneficial to me. And a sponsor is someone who talks about you when you're not in the room. They'll nominate you for awards and promotions. And I can tell you that you can do everything right, but if someone doesn't recognize your efforts and push for you, it may be extremely difficult to get where you want to go. I told you earlier that my North Star has always been making this world a better place for people, caring for others and improving their lives. So when you think strategically about the roles you want to take on, remember to consider whether the opportunity aligns with your values. A few years later, I was in a medical director role overseeing our large outpatient practice at the main campus at Montefiore Einstein, actually walking in Geraldine's footsteps. She had been the medical director at that same site several leaders before me. And I was responsible for overseeing all of operations and finances, working closely with the managers, director of finance, to improve scheduling, staffing, optimizing case volumes, increasing revenue, renegotiating service contracts. And I was optimizing MRI protocols by leveraging industry partnerships with Philips and GE and collaborating with our division chiefs. I had established regular staff meetings and an open door policy. I tried to build a culture of trust and psychological safety among our schedulers, verifiers, PAs, and techs. And in that environment, I was able to pursue a passion project that directly impacted our patients' lives. I tried to address the larger question of imaging access for patients in an underserved population. My goal was to provide world-class care to Bronx patients because health equity problems and disparities were widespread, and the issue of access to MRI appointments related to several barriers that our population was facing: language barriers, low medical literacy, insurance problems, limited scheduling flexibility because of multiple jobs or childcare, and also low prioritization of medical care due to other insecurities such as food and housing insecurities in their lives. So from that perspective, despite providing extraordinary service, we actually, for some patients, had an unnavigatable obstructionist system. When you think about your own interactions with healthcare, even for patients with high literacy, you know that it can be hard to schedule and get an appointment, manage your insurance coverage for that exam, complete exam preps, and you might face multiple specialists that don't directly interact with each other and possibly are part of different health systems. So I really wanted to delve into how we could make the patient experience better in a very challenging, under-resourced environment. And I took this on as a challenge. Briefly, this entailed working with referring providers, IT teams at the institutional level, billing and radiology leadership in order to roll out a direct scheduling program for patients to have MRIs scheduled during their clinic visits while in with their doctors. And the idea was to bring scheduling to the point of care by making slots visible and schedulable directly in the referring offices and by those clinical staff. This was a pretty high-risk proposition, and I actually faced quite a lot of criticism about the risk of improper, inappropriate scanner selection, the need for prior authorizations, the timing of appointments, and multiple additional issues that could lead to wrong scheduling and loss of slots, most of which we were able to overcome. And I can tell you that that success meant more to me than any of the revenue jumps or the team growth that we had seen. The increase in directly scheduled exams meant that we had made life easier and imaging care more accessible to patients who needed that pathway to be successful. So that leads me to principle number 3. Leaders innovate and create. The value here is that leaders are meant to be disruptive to the status quo. That's where the good stuff happens. Leaders are always looking for ways to do things better, and they will not settle for the way it's always been done. They will raise the bar for success and take measured risk. I want you for a minute to consider this transition from learner and contributor to manager to leader. As a contributor, you're doing great work. As a manager, you start tapping the best people to do the work, but you're still sort of tasking oriented. As a leader, now you're solving problems. You're asking, are we using the best tools? Are we doing the best work with the best process and through the best people? So you're strategically thinking about the future. And there isn't a bad category. We need all these people in healthcare, but I'm here to talk to you about pursuing leadership. So as you go through your journey and what you're doing, consider the environment that you're creating for your team. How well are you communicating? Are you reaching everyone? You have to be able to relate to others, to be a strong communicator in order to build rapport and trust and allow people to be themselves. More recently, I was in a larger role than the previous one, scaled up to solve operational inefficiencies and challenges across all sites in radiology, inpatient, outpatient, ED. And here the challenge was building and leading multidisciplinary teams, ensuring timelines and milestones were met. So I was looking at neurointerventional radiology, first-time quality in tray setup in the setting of acute stroke, and MD in-room times for fluoro-guided procedures and turnaround times in the emergency room. So it leads me to the question, how do you effectively lead large multidisciplinary teams? And what I learned is that this really does require relinquishing control and entrusting your team. Letting go. This was very hard for me. For a long time, I took pride in living both in the details and at 100,000 feet. But in order to accomplish at scale and not lose yourself completely, you need to cultivate teams and trust in them so you can be successful in your goals to drive improvements across the system. This is a quote from somebody that I follow, and it's the idea of leading through others. A leader's job is not to do the work for others. It is to help others figure out how to do it themselves, to get things done and to succeed beyond what they thought possible. So leadership is about people. It requires letting go of me and getting to we. It's about the people and not about yourself. What does it mean to be a leader and not a boss? It means to lead with influence rather than hierarchy or authority. And the art of this is cultivating and growing diverse teams so that you can leverage what each team member has to offer. And again, this requires creating opportunities to bring diverse people to the table and to thrive there, because diverse teams can help you drive the change that you are seeking. I'm going to tell you a quick story to highlight that it's often the front line, even the secretaries, that know what your patients will need and what we'll ask for. During one improvement project, I was trying to cajole the ICU doctors to arrive on time to radiology and to have on-time procedure starts. But In truth, the process was taken apart and studied, and there were a series of inefficiencies contributing to the delays. And the physicians were really just responding to the expectation of when the cases would start, and they were arriving then. We had workflow problems that were solved and other supply challenges that we had to address. But the largest issue relating to patient arrival times were only solved by adding the registrars and the secretaries to the team and getting their perspective on what the families needed to be successful for their procedure day. So the message here is to leverage the strengths of your team and go deep into the organization. In medicine, we have the tendency to focus on the symptoms rather than the cure, and you may need to go upstream or downstream to identify the problem that needs to be solved. Which brings me to principle 4. Leadership is about relationships more than anything. There is no way I could have had any successes without having my teams working with me. And I've mentioned this before. We need to move from me to we. We need to lead teams with influence rather than authority and be vulnerable. Seek help and guidance from others and help others get things done or get things done through others. And as a corollary to working with teams, principle 5, lead with integrity. All of your relationships and interactions should align with your value system. I'll share one last personal bit here. Family is incredibly important to me, and despite the challenges and committed time of a career in medicine, I wanted a large family, and I didn't want to wait until I was older. So I had my first child in med school, my second in internship, third in residency, and my fourth in fellowship. I did at some point have nannies signing out to nannies with handoffs paralleling what I had done on the wards in medical school and as an intern. I was always very proud of my motherhood, and I can tell you that it's quite important to be yourself at work, to bring the entirety of yourself to work and to be authentic and honest about who you are. But early on, I definitely thought that I needed to hide at least parts of my home life and not discuss it too much at work, lest I be viewed as distracted or not taken as seriously, because unconscious biases do exist. But in the later years, I became much more comfortable with work-life integration, and this version of me was much more authentic and honest with my colleagues and friends. So my advice to you is to bring your whole authentic self into your roles, and your authenticity will be both valued and appreciated. It turns out we're all humans working in the hospital or your practice, and no one is a robot or completely unbound. So as a leader, be sure not to betray your relationships or commitments, both at work and outside of work at home. So these are the 5 principles that I've shared with you that have been essential to my leadership journey. And my hope is that some of these have resonated for you and have given you some ideas about how to transition into leadership. So here's your homework. Your homework is to define your own North Star, to consider what values or principles will guide your leadership, and maybe as a concrete step, start making a list of mentors, coaches, and sponsors who can be helping you. Now, some of this might be very new to you, so on the next slide, I have a few suggested leadership books. I've included them here as a reference and resource to you. I've enjoyed these and used these as guidance to me in my leadership journey. Thank you for your attention, and I look forward to your questions and further discussion in the live QA portion of this program. Please know that I am always open to your feedback. Feel free to reach out to me over email or through Twitter. Thank you very much.
Good evening, everyone. I'm Eleanor Gillis. I'm one of the co-organizers, along with Danya, Kerry, and my colleague who will be helping moderate this second Q&A, Nisha Sankaran. We do have a few questions for our most recent speakers. Thank you so much for those wonderful presentations. Our first is from Michael Hood, who also says thanks for the presentations, and talked about the description that we heard of the process involving the transition from managing, from learners to leaders and becoming a leader rather than just a manager. He asks, was this transition gradual for you or was it more discrete? Namely, did you actually organize these efforts yourself or did they kind of happen as you went along? And we'll open that up to both speakers, please.
I'll start, and thank you for that excellent question. I think it's a very good one. Probably the best way to answer it is to say that for me, I was probably doing a lot. I was probably doing a lot more than my titles suggested for a very long time, if that's a helpful thing to say. I think that the answer is it was extremely gradual. I was, getting involved in one area, fixing a problem, and then getting involved in another area, fixing a problem, and meeting people in the organization along the way, and sort of slowly building my network, and also trying to kind of figure out what it is that I enjoyed. And not every thing that you throw at the wall is going to stick. But so for me, it was very circuitous, and I would say pretty gradual. And then eventually, I got to a point where I kind of knew what I wanted. And then I did that for some time. And much later, it got like a rubber stamp and a job description and a set of responsibilities after, discussions with, leadership in the department. So I think, to sort of complete the answer, my advice to you is if there's something out there that you're interested in, or a problem that you think needs to be solved, or a group of people who are doing something that you think is interesting, just go for it, because you don't know where it's going to lead you. And usually you'll learn something in the process, and there's no road that's sort of defined for anybody. And so you have to just begin somewhere. But definitely gradual, and most certainly from the ground up, and just, start taking on responsibility, and you'll go from there. That's been my experience.
Thank you. Dr. McGinty?
Well, when you're as old as I am, you typically have a lot of different experiences to draw from. And my first real leadership experience was when I started at Montefiore, and it was pretty much my first job out of training. And I was hired to start a new outpatient imaging center. So I went from training to all of a sudden having to hire staff and go to construction meetings and understand budgets. And so I was really thrown in at the deep end. I think after a few years, it became obvious that, like you said, Shlomit, I needed some tools. I was kind of winging it some of the time. But I've had other times in my career. When I started at Weill Cornell, I did a bit of a transition in my career, and I just started with a part-time clinical role, but it became clear that they were going to need someone to take over the contract negotiations for their insurance contracts. And I wanted that job. And I went around to lots of people and I said, please, can I have that job? I think I could be good at that job. So, I've had different types of experiences.
Thank you.
So the next question I have is, it's actually from me. So my question is, for someone who's just started a job, it's been a year since you've been in practice, and you've slowly come to realize that you are interested in leadership. Do you think it's a good idea to get additional training in leadership, or do you think we should just join committees to start with without any background and wing it?
I'll take a stab at it, Shlomit, and then I'll turn it over to you. I think it is always a good idea to start building your skill set. Different people will have different bandwidth and different ways that they want to do that. The RLI is a great way to start building those skills. There's a lot of great content that you can consume at your own pace. People often ask me about an MBA. I definitely feel that you want to make sure you're a little bit further on in your career, that you actually have some managerial responsibilities, because an executive MBA is really dependent on your ability to take what you're learning and use it in your day job. But, at the end of the day, those committees, not only are you serving, but they are often really great learning experiences. You'll see people who are senior, people who are experienced leaders, and not only will you be doing valuable work by volunteering, you'll also have a real opportunity to learn.
Yeah, I couldn't agree more. I started as a first-year faculty member in the musculoskeletal division at Montefiore. And I remember very clearly feeling like there were a lot of things that had to happen all at once. I had to get pretty good at teaching, right? And I had to get pretty good at final signing reports and also taking more general call. And then what was I doing in terms of research? And do I have any passion projects? Kind of where am I going? And so everything does kind of open up to you, right? Almost sort of at the same time, especially if you're transitioning to a new institution where you hadn't trained and there's just a new set of rules and a new set of people. And I remember feeling, you know, I'm not really sure exactly where to get started. And for some people, it's okay to sort of hunker down and get comfortable before you figure out what your next step is going to be. And I can tell you that for the first few months, you know, I arrived with 4 children, you know, under the age of 7. So it was a particularly interesting time for me. But I definitely spent time focusing on my clinical work and making sure I was really good at what I was doing and developing some street credibility with my referring providers and attending, you know, tumor boards and learning and listening and understanding who people were. But I will say that the first committee that I volunteered for was an ACR committee. I believe it was a value-based payments committee. And it was led by Dr. Giles Boland, who had been one of my attendings at Mass General in the body division and has since gone on to do amazing things. And I learned so much from that experience. I met people who were doing very interesting things. I learned new terminology. I read articles that were introduced to me through that work. And I remember feeling very insecure, like I wasn't contributing very much. Everybody else on the committee seemed to know a lot, but nobody on the committee seemed to care that I didn't know as much and that I was asking a lot of questions. And I think that what you'll find in the ACR and in academic medicine is that people are really interested in helping to develop you and your career. And undoubtedly, committee work at the national level is going to take you to new places and new experiences with a pretty sort of low bar for entry. And so I absolutely recommend that, in addition to more didactic and experiential coursework through the RLI and other societies. So I would say, to answer your question, I don't think you need to jump into a leadership training program in your first year, you know, out of fellowship. But I do think you need to open your eyes and expose yourself to people and committee work and coursework that will at least give you an idea of what you're going to be interested in and what grabs you. And that's the way to start, I think.
That's great advice. Thank you so much. Thank you.
Along those lines, as you have these opportunities to get involved, a question that we have from the audience is, how do you decide which opportunities to take on and which ones to say no to? And if you have to say no to an opportunity, then what's the best way to do so?
I would say that early in your career, it's probably a good idea to cast your net reasonably wide, you know, with obviously respecting your time and your bandwidth. But, you know, my volunteer career at the college actually started in quality and safety, and you can see how fulfilling that pathway has been for Shlomeet. It really wasn't my thing, but I kept showing up to different volunteer opportunities, and then I found economics, and that was absolutely the place I was delighted to be. As you get further on in your career, you definitely have to be better at focusing. It hasn't always been a skill of mine, but I think there's a couple of things. If you don't think you're going to be able to do it, be honest. Get your response back quickly, and just say, right now I don't have the bandwidth, but I'd be delighted to be considered for future opportunities. And for me at this point, if I'm being asked to speak and I don't think I can do it, I will always suggest a couple of people, and that's a way for me to sponsor people as well. This person would be great. You know, why don't you reach out to them?
Yeah, I completely agree. I think, you know, especially when you're first starting out, my opinion is it's okay to sort of err on the side of saying yes too often, unless you really don't, again, have the time to meet those commitments. But you do want to seek out challenging experiences, and you want to solidify your framework for future roles. And so if there's something that just really is not something you're going to be interested in, it's much much better to politely decline with some constructive sort of advice to the person seeking help than to sort of carry it on and not be passionate about it, and then maybe not meet the expectations or be the person that they need you to be in that role. The other sort of piece of this that I think is really important is that if you're at the point where, your plate is full and you're really looking for different or larger opportunities, or if there's an opportunity that comes to you and it really just doesn't align with your North Star, it doesn't align with your personal mission statement, it's not where you want to be, you don't even know if you necessarily be good at it, keep in mind that saying no to something allows you to say yes to something else. And it's a really it's hard, I think, when you're starting out and maybe you're a self-conscious overachiever and you're going to always say yes and do more and pretend that you have all the bandwidth in the world. But keep in mind that every commitment that you do make, it does theoretically replace a different commitment that you might be more passionate about. So you can certainly feel free to choose wisely. And I think that people are receptive to, doctors who say, that just really doesn't align with what I'm interested in, but I think that there are others who would do a better job, and I have some suggestions for you. So I think it's good to err on the side of saying yes early on, but it's also really okay to say no to make room for other things.
Great. So we have one more question from the attendees. The question is, how long in one's career does it take to understand what they want their niche to be?
So, Meet, I'm going to let you go first on this one.
I think that's a really, really excellent question. And I think that it's a highly personal one. I think for some, they know very early on, and for others, it can change a lot. I think this came up earlier when somebody asked the panel, how often do you need to sort of reevaluate your mission statement? And Dr. Robbins said, well, at least once a year, kind of take a look at what you think you're doing. And that's sort of the question of, well, what is your North Star and where are you going? And do you have a mission statement? I think that, for some people, when you think about it, there are some people who knew they wanted to go to medical school when they were 6 years old, and others who came across that career path later on. I think the same is true when you're sort of developing your niche and who you want to be as an adult radiologist. It can take a different amount of time for different people. And so I don't think that there's really a cookbook for it. But I do think that in order to bring yourself forward and to make sure that you're moving forward and not moving back, is just keep having those experiences and putting yourself out there to learn new things and to be around people who are doing things that you find interesting. And that's really the best way to figure out where you get your jollies, because if you don't try it, you won't know. And there's no timeline on it. So.
Yeah, I couldn't agree more. And, I admire people who are really focused on one particular area their entire career. I'm not one of those people. And I think, just as Shlomit said, leave yourself open and, really give yourself the chance to experience different career paths or different areas of interest. Commit while you're there, do the best you can, but if it's not for you, then move on, and never think that you're too late in your career. I sent in my first research protocol to the IRB last autumn, and I'm having a great time working on it. So.
All right, we have one more question. This will be the last question. The attendee has thanked you both for your great insights and has asked, what steps did you take as a resident to develop your career as a future leader?
I'll start with that one and then pass it off to you, Dr. McGinty. So I think that the most important thing that I did in residency for my future career was establish some real good mentors. And I think I only really knew that later on when I came to rely on them. And I realized that they were there for me and I had kind of done something right. So I think it's a sort of a lesson learned. make sure that the people who you connect with, the people who you do work with, the people who understand you, and who sort of align with you, make sure you keep them close to you, and learn from them, like drink from the fountain. It's there for you. And so as a resident, one of my greatest mentors is an abdominal radiologist named Dr. Susanna Lee. She's also at MGH, and I can't say enough things about how she just was there for me when I needed her at various sort of moments in time where I wasn't sure about something, or I needed to make a decision, or as Dr. Pari said earlier, when I made a mistake and I just needed to sort of bounce that off the right people. So if you can establish strong ties to people that you learn from and carry them with you wherever you go, I think that that's something that will serve you extremely well as you move on from your residency and your fellowship into your future career. And I know that that has served me extremely well.
So I was chief resident, and that was an incredibly formative experience. I had experiences of having to call out, bad behavior, and obviously Pittsburgh was a big residency, so there was a lot of day-to-day operations to think of. But probably the most long-lasting impact was that I looked at people who seemed to really love their work and seemed to be combining aspects of their work that were interesting to me. I worked with people like Ellen Mendelsohn, who's a legendary breast imager, Dr. Harvey Neiman, who was the late Harvey Neiman, former CEO of the college. And I saw what they were doing, and I sort of looked at how they were contributing in what different fora, and their career paths were very inspiring for me.
Thank you so much. That was such great advice. Thank you to both the panelists, Dr. McGinty and Dr. Stein. That was really great talks and wonderful webinars, and really appreciate all the advice you've given us. So we're going to close off this evening. I'm going to hand over to Dr. Norbash, who's got some closing remarks.
A delightful program. I'd like to thank all the participants. I'd like to thank Anne-Marie Pasco and Vicky Giannotta for organizing the session. I'd like to thank Carrie Vincenti, Dr. Vincenti, for the several years she's put into this, and the thought, the effort, and the passion for making sure that this becomes established as a landmark program. I heard quite a bit this evening. I heard a lot that was complimentary and that echoed positive messaging, and I'd like to go over it a little bit if I may. I heard Dr. Robbins talk about the need for us to find our passion, to look inside ourselves, and to dream big. I heard Dr. Pandare Pandey tell us to look at failure as growth opportunities. Know that we not only will recover, but we get stronger from each failure. To create a culture of experimentation, and to know that just as in basketball, you can't make shots unless you take shots. I heard Dr. Fair say that you have to know the job and your ability to do it. You need to find a sponsor. You need to know how to ask for help. I heard Dr. Spoluto say or show that you can learn from the journey of others. So be observant, network, think, acquire the skills you need, ensure that you have the right tools for the job, and know that you have the job that you want. The question and answer session for the panel was very positive. Understand how you will best contribute to your chosen department and organization. Be strong, constantly learn. Dr. McGinty shared with us the need to understand and learn in a dynamic manner. For example, learn about the new power compass, so you'll understand connectors, castles, crowds, cheerleaders. Know what your tasks are. Know what kind of organization you inhabit. Know yourself. Network up and down and all around. Know your team and understand the essential value of stakeholders. Dr. Goldberg-Stein told us to elevate our vision, to know your North Star. Know that you are unique. Know that you therefore have the ability to uniquely make the world a better place. And so please Consider that your task and do exactly that. Dream big and then do big. We heard a lot of words this evening that were repeated, concepts that were repeated. What words were they? Mentor, sponsor, stakeholder, learning, networks, skills, experiences. And ultimately, I would like to submit to you that a lot of what we heard are embodied in two large concepts. One concept is relational, community building. And that's something that's happening dynamically. This evening, for example, you saw the respect and admiration that our speakers had for each other and how they complemented each other, built on each other, and created a community of learning. And that's the second word, that's the second concept, learning. That we actually have the ability to grow through engagement with others, through understanding concepts and approaches that we otherwise would not understand without the opportunity for communication and learning. I'm very grateful for the privilege of closing the program. We're happy that this is an essential part of our annual summit, and we're looking forward to your participation in the summit. So again, I thank you very much for joining us, and I look forward to seeing many of you, hopefully, over the next couple of days. Thank you.